So just want to let everyone know I'm talking about a number of different devices today. I don't have any stock in the manufacturers. I don't get any remuneration from anyone. So I just want to make sure you're aware of that. This is a slide I like to start with that kind of lays out the brain stimulation modalities that we have available, which can be broadly divided into non-surgical and surgical, and then within the non-surgical, convulsive and non-convulsive. And over on the surgical side, you can see vagus nerve stimulation and deep brain stimulation. So today the talk is in three parts. First part is is focusing on ECT and what we do, what's been going on here recently at Hopkins with ECT. The second part is on convulsive therapies more generally and the effort that has been made over time to reduce the cognitive side effects, which of course is a major concern for a patient undergoing ECT. The effort that has been made, an ongoing effort to reduce cognitive side effects. You can see a couple of experimental treatments listed under the convulsive heading, MST and FEAST. I'm going to talk with you a little about each of those, particularly MST, as it could win FDA clearance at some time soon. And then the third part of the talk is just to talk more broadly about some of the non-surgical, the non-convulsive brain stimulation modalities we have, and some recent studies in that along those lines. So that's what we're going to do, and let's get started. So what's happening with ECT at Hopkins? And this is kind of been more topical than usual right at the moment over the last couple of months, because our volumes have been quite high. Every year or two we kind of go through cycles where our volumes really go up high, spike I guess, and then they gradually subside, and we've been going through one of those spikes since the winter holiday period, and so we've been reflecting a lot on kind of how we do things here and what might have changed. And I've been running ECT for almost 20 years now, and what I've listed here are really a couple of the major changes that have happened. One is the introduction of remifentanil. Probably many of you have seen our notes mentioning that, which is an opiate that allows us, when we combine it with methotrexate, the anesthetic agent, to lower the dose of that, which is important because it's an anticonvulsant, methotrexate, and as the seizure course progresses, the seizure threshold rises, and we have increasing difficulty generating good quality treatment. So we often introduce remifentanil. But remifentanil probably also slows down the recovery time, so it's contributed to longer times in the ECT suite for our patients. So that's one change that certainly could be contributing to longer days. Now we've also, like many places around the country, we've increased the proportion of patients that we treat who are outpatients. We probably still treat less, almost certainly, than the majority of facilities with outpatient care, but it's certainly increased from where we were 20 years ago. And then the other major change that's happened in the last few years is the increased number of children and adolescents that we've been treating. And I'm going to really focus on that in just a moment. But here's, with the help of Susan Four and administration, some data for the last 7 years. So last data is from fiscal year 2024, so that's July 23 through to June 24. And dating back to fiscal year 2018. Now, the first thing I want to point out is just, before we look at the data for the kids, if you just look under the adults, you can see that, and they're split up into inpatient and outpatient, you can see that in fiscal year 2024, it was almost even, the number of inpatients and outpatient sessions that we did, which is quite a contrast to the way things were back in 2018. Okay, and so what I'd like you to take a look at now is the 17 and younger, and you can see that there's been a marked increase in the number of ECT sessions we're delivering to minors. And if you look in fiscal year 24, you can see that of the total, 388, out of the 2403, it's over 15%. And I just looked in February, just last month, we averaged 16.3 cases a day, and 3.7, so 23% were minors. So really quite a high proportion. So what's been going on here? So I went back, and Susan, Cindy Haynes in John Camper's office helped me identify, well, I think I have the vast majority of patients, minors, treated over this over the 7 years. 34 patients we identified. 25 referred from our department here, or pediatrics, and 9 from the NBU at Kennedy Krieger. 20 of those 34 had intellectual developmental disability, and 12 of those 20 had on the autism spectrum. Now, of the remaining 14, 8 had MDD or bipolar depression, the absence of a developmental issue. The remaining 6 had a variety of schizoaffective, early onset schizophrenia, psychotic psychosis, NOS. Was one child with NMDA receptor encephalitis. So then, looking further about the actual the presence of catatonia, which is a common indication for this age group, 8 of the kids were referred for kind of stereotyped intractable self-injury or agitated catatonia. All of these children had intellectual developmental disability, and 12 were referred for the more classical kind of akinetic catatonia. Again, most of those, but not all, had an IDD. So you might say, well, this trend in the increase of minors at ECT it seems to be mostly driven by kids with neurodevelopmental problems, but it's certainly not exclusively that. And I looked back at some data we published a number of years ago. We did a study where we were looking at trying to characterize adolescents and young adults getting ECT, neurotypical, so not kids with IDD, and learning more about their courses and risk factors and what would determine the length of their ECT course. And we did a very careful search at that time. It was 8 years inclusive, 2007 to 2014, and we identified 48 neurotypical, so no developmental problems, adolescents and young adults, 25 and under, who we had treated. So that's over an 8-year period. Now, I looked back again just in February, just last month, and there were 10 patients under the same group. So these were young adults and adolescents, no developmental problems, who were either in the middle of an acute course or were getting weekly treatment, had just stepped down for an acute course, certainly suggesting that that the numbers of young people, adolescents who are neurotypical has also increased, who are getting ECT. So just a little of the history. So ECT for minors is not a new thing at all. ECT was first administered in 1938 in Italy. By 1943, there was a publication from France, George Hoyer, who was a leading child psychiatrist in France, of 40 children aged 5 to 19 of the Salpêtrière who were treated with depression, melancholia, mania, and schizophrenia, and found some good results for the kids with melancholia. And then Loretta Bender, who was here at Hopkins for a time, reported on a case series of 98 children as younger than 12 at the Bellevue Hospital in New York. Many of those were diagnosed with so-called child schizophrenia that by contemporary criteria would be have a neurodevelopmental disorder such as autism, and again finding a very good response to ECT. So what's been going on more lately? The data that there is out there. So James Lucarelli, who's a child psychiatrist up in Boston, did a search of a database from cases from 2019, almost 4,000 hospitals, 4,000 hospitals, and looked at the child hospitalizations and the number of kids getting ECT, and found the rates were extremely low and comparable to what was found in 1980. But what's been going on more recently, right? So this data is really about the last 5 or 6 years. So, so this is data. This is not patients. This is PubMed publications showing interest in the topic of childhood ECT. I just searched under electroconvulsive therapy and child, and you can see in the last 5 or 6 years there's a lot of interest in this topic. But what's going on in the rest of the country? And we don't really know. I've certainly heard anecdotally from colleagues that they're also seeing increased numbers of kids getting ECT. And I've heard of a couple of pediatric hospitals where they're thinking of introducing their own ECT services, a couple of services around the country. So we don't know really for sure what is happening. We certainly see what's happening with our service here. Certainly there's been a lot of studies over the last few years suggesting increased burden of mental illness, including ER visits, prolonged ER visits amongst adolescents and young adults. So the increase that we see could certainly reflect that. The other issue is that there's been I hope some destigmatization and increased comfort with receiving ECT. The FDA finally cleared ECT for 13 and older in 2018. The ACAP, the American Academy of Child Adolescent Psychiatry, has guidelines now, so hopefully that's helped contribute to the destigmatization. Okay, so that was topic one. So the next thing I wanted to talk about is more broadly convulsive therapy and what's happened and what may be happening in the future to decrease the cognitive side effects associated with ECT whilst maintaining efficacy. So I think we should just start by saying that we don't really have good interventions to decrease the cognitive side effects. So there have been some studies, pharmacological studies, memantine, donepezil, and have they not been proven effective? Certainly I've seen anecdotally some patients, taking these medications who feel they may help, but there's no real hard data showing that. There's also some pilot studies of some cognitive therapies trying to improve performance and enhance coping. There's one kind of group therapy, a study with group therapy done that McLean has pioneered, that they've done some pilot work on. So really then the major focus is what can be done technically with the treatment itself to try to reduce the cognitive side effects. So let's just start with a little bit of history. So the panel here you can see on the right, you can see a sine wave at the top. And the early ECT devices used this kind of crude sine wave, which is really what comes out of the power outlet, to trigger ECT. And there were severe memory problems. There are various case series where 30, 40, 50% of patients had to stop ECT because of the cognitive problems associated with sine wave ECT. And it's probably there's a lot of electrical shunting that occurs with such high charge that gets shunted to parts of the brain that such as a hippocampus that may be particularly sensitive and help contribute to the cognitive side effects. It may be that you're also stimulating neurons during the refractory period, which is a highly inefficient way to use your charge. So there's a variety of different things different elements to the very high charge that is probably contributing to the cognitive side effects. So there were modifications made in the 1970s to the ECT devices with the introduction of so-called brief pulses. And you can see here these rectangular pulses so the total charge is essentially the area under the curve, and so the charge is far, far less than with the sine wave devices, and it also gives us the opportunity to adjust a variety of parameters, the pulse width, the current or the amplitude, the frequency of the pulses, and the stimulus duration. And it was shown conclusively that the cognitive side effects are far less with the introduction of brief pulses. And nowadays, really, there aren't, I don't believe there are probably any sine wave device in active use, at least here in the United States. So, one more recent modification has been to try to decrease the cognitive side effects associated with so-called brief pulse ECT still further by reducing the pulse width. And there was a landmark study published by Harold Sackheim's group in Columbia in 2008 that showed that if you gave so-called ultra-brief pulses, or pulses with a pulse width of 0.3, compared with a regular pulse width in 1 to 1.5 millisecond range, that you had reduced cognitive side effects, including both acutely delirium and longer-term cognitive side effects. What has also been shown in the ensuing time is that whilst there certainly seems to be an effective treatment, the response rates are comparable, that overall remission rates may be somewhat lower, and the patients do take longer to get better. Nonetheless, it's certainly worth a try in people who are ECT naive. We start them all off almost always on ultra-brief pulses, but then we widen out the pulse width if they're not responding. So this is all, everything I've mentioned is all regular clinical practice. Now so this kind of illustrates the issue of cognitive side effects. You see sine wave with the biggest, worst cognitive side effects at the top, brief pulse, reduction, and ultra-brief pulse. And then what about these other treatments, which are experimental, but I think it's important just to talk with you about them. Low amplitude, ILAST, I'll talk with you about that in a moment, and FEAST, and then I'll spend a bit more time on MST, because I mentioned that's a technique that there's a good chance will be cleared by the FDA in the next year or two. So low amplitude ECT, so the amplitude or the current can be adjusted. It was one of the 4 parameters I showed you earlier that we can adjust with these brief pulses, and kind of almost by convention, the current that we've been using, that is certainly even built into some of the parameter sets on these devices, uses 800 or 900 milliamps. But the data supporting that is really not there. And so there have been some small studies looking at lower current in the 500 to 700 range that seem to be associated with reduced cognitive impact, but also reduced efficacy. So now there's an interest in trying to understand, work on that a little further by essentially identifying what might be the lowest current needed to trigger a seizure in someone, kind of a seizure threshold titration using current, and then figuring out what the multiplier is for that individual. So titrating individually to try to optimize the efficacy whilst also reducing the cognitive side effects. This is all still kind of in the relatively early stages. I mentioned the acronym is FEAST, focally electrically administered seizure therapy. So the standard treatment, right unilateral, that we start off almost all patients with. We have one electrode over the vertex, over the parietal lobe, and one on over the temporal lobe. But what about if we stimulated much more focally over the frontal lobe? And that's the idea behind here, where the electrodes are placed over the kind of fronto-orbital cortex. There's still a generalized seizure-induced, and there have been a couple of kind of open-label studies looking at this and suggesting that you can maintain efficacy, perhaps with some reduced cognitive side effects. Again, still pretty early days. This, however, is coming online, I think. This is essentially triggering convulsion with a TMS device that was developed by Holly Lisenby and Harold Sackheim about 25 years ago at Columbia. And it's clearly associated with less cognitive side effects. The question is it as efficacious as ECT? So with a TMS device, so with ECT, there's a lot of shunting that goes on of the electrical current around the skull and the scalp. With a TMS device with an electromagnetic wave, there's no shunting that passes completely unimpeded through the skull and the scalp, and is very focal and triggers an action potential of the neurons directly underneath. So the seizure, the trigger of the seizure is much more focal, so is this a way to reduce the cognitive side effects, which clearly seems to be the case by not involving other parts of the brain, such as the hippocampus, where we know, or we certainly think, that the cognitive side effects, at least in part, come from. So the EEG is quite different in these patients. We don't get the same post-ictal suppression that you do in ECT, which is actually the best marker of efficacy in ECT, and that's why we quote it to you as part of the report, how good the post-ictal suppression looked. You don't see that. It doesn't correlate with outcome in MST. This is the device. It's a butterfly coil. And this study that's just finished last year and is going to be reported out probably any week now. This is a 3-site study. Started with Jeff Daskalakis in Toronto in collaboration with UT Southwestern, and he moved to UC San Diego. So it became a 3-site trial of MST versus right unilateral ultra-brief ECT. And it's a non-inferiority, so it's a double-blind, randomized, non-inferiority study, and to see that if it's as safe and effective for treatment-resistant depression. So the patients are all non-psychotic patients with MDD. So not necessarily the sickest of the sickest, but they're certainly our treatment-resistant depressive patients that we treat all the time. And it's a rather prolonged protocol over 7 weeks, 2 to 3 sessions per week, and as I mentioned, the patients are randomized to ultra-brief or to MST. So that is going to report out, as I said, very soon. And if they've enrolled, I believe, about 220 patients. If it is found to be non-inferior, then there's a good chance that the company will be successful with FDA in getting clearance for MST. So now, third topic is to talk just more briefly about, and just kind of update you on some of the recent studies in the field more broadly. Firstly, on TMS. I mean, a couple of studies that came out in 24. This is with conventional TMS as opposed to theta bursts that Kevin Lee spoke about a couple of weeks ago, and I'm going to touch on in a moment. This is the old-fashioned kind of conventional TMS, comparing it with switching antidepressants for patients with TRD. One group, Marcia Fava at Harvard, compared a course of TMS with a switch to venlafaxine or augmentation with Abilify, and another group in Holland compared with a course of TMS with a kind of algorithm-based medication switch. And in both cases, they showed that the trial of TMS was more effective than the switch to a new medication. So what about accelerated theta bursts, which has kind of been the hot topic in the brain stimulation field in the last few years? And Kevin spoke quite extensively about the Stanford protocol, and we did a pilot here a year or two ago. And so just to remind you, this combines this so-called SAINT protocol combines an accelerated protocol of giving 90,000 pulses over 5 days, 10 hours a day on the hour, hourly for 10 hours, with theta bursts, which is a more efficient way and mimics the endogenous kind of firing of neurons undergoing kind of learning and memory. So a more efficient way of delivering the plasticity and neuronavigation to try to optimally identify the target site that we think is most likely produce an antidepressant response, and that utilizes a very sort of fancy resting state functional MRI baseline. Resting state fMRI to identify this target, and the so-called SAINT protocol itself is actually has been commercialized by a company, Magnus Medical, affiliated with Stanford, and it's proprietary. The algorithm they use based on that data that the individual sites are uploading. So all that being said, the treatment was cleared by the FDA in 2023. There's been a slow uptake, as Kevin showed the other day, in sites actually administering the treatment kind of by the books. So one obvious question is the way the company makes money is that they charge essentially for giving you the targeting coordinates. So is it really necessary to have this sophisticated way of finding the target? So Yvette Shailene at University of Pennsylvania published last year a randomized trial of 24 patients with bipolar depression using the same SAINT stimulation protocol, the 90,000 pulses of theta bursts over 5 days, but she used publicly available methods for analyzing the resting state data and doing the targeting, and she found comparable results to the so-called SAINT data that had been published by Stanford a couple of years ago. What we have used in just conventional TMS for the last 15, 18 years is it's a so-called beam named after William Bean, who was in Mark George's lab at MUSC 15 years ago. It's essentially using scalp measurements to identify the optimal site, which approximates really very well the site that can be identified on neuronavigation with imaging, the dorsolateral prefrontal cortex, within 1.36 centimeters, 95% of subjects, using that very simple algorithm that we've used for many years when we used our figure of 8 coil. So the obvious question is, would using with the SAINT protocol, using this very simple method of targeting, would the results be just as good? And we don't know. So there's all of the data with SAINT use the figure of 8 coil, which is like a figure of 8 with the field very focal at the center of that figure 8. Nowadays, many places, including our own, have the so-called H coil, which is like a helmet that stimulates much more, it stimulates deeper but also somewhat more diffusely than the figure of 8 coil, and does not involve any neuronavigation or really any complicated kind of positioning. So the company that makes the H-coil is running a trial that is probably going to finish up in a few months using accelerated theta burst, a somewhat different protocol from the SAINT. It's a little more patient-friendly. It's not going on for 10 hours a day. And they had already published some preliminary data, open-label data, using this protocol came out in 2023 that looked promising. So the BrainSway company will come out with their own data probably by the end of this year. And again, it's a non-inferiority study compared with conventional TMS using their H-coil. If that proves, if the accelerated theta burst proves to be non-inferior, then they will go to the FDA and seek clearance for their device for accelerated theta burst. I just wanted to briefly mention vagus nerve because there was a pivotal trial that just published a few months ago. This was the so-called RECOVER trial, which was co-sponsored by industry and CMS. And Scott Aronson at Shepard Pratt was quite involved. A large number of patients were randomized. They all were implanted, but the people, there were some who didn't have it turned on for 12 months. And then they looked at the outcomes. So what they found is that on the primary outcome, the decrease in MADRS, that the active arm failed to differentiate from the sham arm. There were some positive effects on secondary outcome measures, but it failed on the primary outcome. And they're now looking at bipolar depression, and that data will come out soon. I just wanted to remind you about the ECT ketamine work. We've done some of that here. It's still ongoing. The ELECT-D study came out a couple of years ago now and showed ECT IV ketamine to be non-inferior to ECT in non-psychotic patients with major depressive disorder, who were, and 90% of those who were outpatients. However, a study run a little while before from Scandinavia, where they were all inpatients, 17% with psychosis, they found ECT to be superior to ketamine. So just to summarize then, I think without a doubt, still for our most severely ill patients with depression, especially with catatonia, psychosis, ECT continues to be the gold standard and probably will remain. Of course, we need to see what happens with MST. But for patients with treatment-resistant depression who are less ill, then I think we need to think about these emerging technologies. Thank you very much.
Thank you, Dr. Reti. Fascinating issues. It's such a hot area, and there's a ton of interest in it. It's great to be updated this way. I'll pick up where you left off. You talked about the ketamine versus ECT study, which of course got an awful lot of attention. Yeah. Has there been a direct head-to-head ECT versus TMS study in a comparable way? I mean, there have been some early studies from the early 2000s that showed that ECT was more effective. I'm not aware of. I actually asked when we were talking with the Magnus Medical people more when we were doing the SAINT protocol, I had spoken with them about maybe doing something along those lines, but there was no interest in that. So. Okay, thanks. Questions? Dr. Gilbert.
So are you referring to, so there are many clinics that are offering so-called SAINT protocols without the fancy neuronavigation. It's not FDA cleared. I don't know how they're doing the charging. It's not something that we're endorsing. When we get a call like that, we're not recommending that patients do that. I don't know. I'm not aware of any data that's sort of, like observational data that's being published out of those, private clinics. I don't know. I mean, we, as you know, we use our brain sway device a lot more. I mean, we'll see what happens with their own trial, but if that proves to be comparable and gets FDA clearance, then there wouldn't be need for neuronavigation if you're using the brain sway device.
Thanks. Dr. Redgrave.
Thanks, Irving. That was great. I have two quick questions. You mentioned that remdesivir prolongs recovery. I just want to be clear that whether you meant really only within that treatment day and not over the course of a hospital.
Yeah, just in the PACU and immediately after the treatment in the PACU. Yeah, it's a very brief-acting opiate, very quickly metabolized.
Thank you. And then my second question was just back to basics. Is it still the recommendation for most patients getting ECT that they be off of antidepressants when they undergo treatment, or is that a bit nuanced?
Yeah, I mean, there aren't really. We did a study looking at this a number of years ago and did not find that medications actually predicted delirium, and I don't know that there are good studies that demonstrate that. So I think it's more sort of anecdotal experience. Obviously, anticonvulsants are a problem for obvious reasons, and occasionally we do see patients, who are on an anticonvulsant for a particular reason have to remain on it, and unless we turn up the charge or start with a low dose of Brevitol with remifentanil straight up, we do have a problem.
Great. Thanks. Other questions, Dr. Morrow?
Thanks so much. Do you think there's a role for maintenance treatments?
Probably, but I mean, insurance carriers are not typically covering, and Medicare and Medicaid specifically say they do not cover it. And there's really only been one study I'm aware of that looked at monthly TMS for a year in patients and did not find that it improved, reduced the rate of relapse. It may be that you need to administer it more frequently than once a month, but we don't really know for sure.
Interesting. Thanks. Anybody else? If not, we have one more. Yeah, go ahead, Dr. Brett.
Thank you. Really interesting. I'm curious about some of the differences between seizure characteristics in MST versus ECT. You mentioned two of them, but I get this sense that from what we're seeing with post-ictal EEG, that there's something neurophysiologically that's different about this seizure that's being induced. Do we know what that is?
Well, yeah, I mean, I think that, the post-ictal suppression, really reflects just the amount of neurons that are being involved in the seizure, that many of the inhibitory neurons then are, releasing GABA, adenosine that shut down the treatment, just kind of reflecting the amount of tissue involved. Here, and this is a much more focal treatment, you don't see anything like that. Now, I don't have we haven't done any MST here, so I'm, I can't say that I've, seen it personally, but that's what's reported.
With that, we'll wrap up. Thank you for a wonderful grand round.